So welcome everybody to Just Updates from CTOS. CTOS stands for Connective Tissue Oncology Society. It's a meeting that took place in November of 2022. During this seminar, all participants will be in a listen-only mode. There will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. Please remember that information provided in this web seminar is not intended as a substitute for your physician's guidance and care. We would like to thank Blueprint Medicines, Genentech, Decipher, and Novartis for their educational grants for our webinar series. My name is Sarah Rothschild, and I'm the Executive Director of the LifeRaft Group, and I would like to introduce our presenter for today. Dr. Herbert Loong holds conjoint appointments of Clinical Associate Professor in the Department of Clinical Oncology and Deputy Medical Director of the Phase 1 Clinical Trial Center of the Chinese University of Hong Kong. He's also the current and founding convener of the Prince of Wales Hospital Adult Sarcoma Multidisciplinary Team. Dr. Loong obtained his medical degree with a distinction in surgery from the University of Hong Kong in 2003. And he's a recipient of the European Cancer Congress Fellowship Grant, the American Society of Clinical Oncology Annual Meeting Merit Award, and the Hong Kong College of Physicians Young Investigators Award. It's a pleasure to have him here today, and I'm going to let him begin his presentation.
Thanks very much, Sarah, and thanks again to the LifeRaft Group for inviting me to give a overview of some of the recent conferences and congresses. So welcome everybody. Good morning, good evening, good afternoon, wherever you are in the world. I'm Herbert Loong from Hong Kong, and right now it's 8:03 in the morning, and I hope it's a convenient time for all of you as well. So as Sarah has already described, today we'll just be going through some of the key abstracts in GIST that was presented at the CTOS meeting earlier last year in November 2022. And I'll just go on and share my slides, and then hopefully I'll take you through some of the abstracts in the next 25 to 30 minutes, followed by some Q&A and have a fruitful discussion as well. Okay. Let me make sure I'm sharing the screen properly.
Yep, I can see it.
Are you seeing the proper slides?
Yes.
Okay, good. Thank you. All right. So before I begin, these are my disclosures. And a quick disclaimer is the fact that the slides being used today, the copyright do belong to the original authors or CTOS, and these are being used by courtesy for this educational event. The choice of the abstracts that I'm discussing is really based on my own assessment for their academic merit and its contribution to the GIST community, and it really does not necessarily reflect the views of CTOS. So just a quick background for those who may not be aware of the CTOS meeting. CTOS stands for Connective Tissue Oncology Society, and it is the premier sarcoma or connective tissue disorder meeting annually. And this year, actually, we had close to 1,000 attendees. I believe actually it was 985. And this was the first face-to-face meeting that we've had since the pandemic. And we've actually had the prior two meetings being held virtually. And specifically within every single CTOS meeting, there's always a dedicated GIST oral abstract session. And there are also multiple GIST posters that were presented. And this year was held in Vancouver in November. So I highlighted 5 key GIST abstracts that I would like to discuss today. There were certainly more than 5 that were submitted. I think in total, there must have been about close to 35 to 40 GIST-associated abstracts. But I've decided to choose these 5 mainly because of its importance in the field and also its potential influence of how we're going to treat as well as how we're going to monitor GIST patients. So to begin with, there were 2 oral abstracts that were presented, which I will be discussing. One is by Dr. Lapotiano and colleagues, which actually looked at a novel prognostic system for patients with high-risk KIT exon 9 mutated GISTs who were treated with imatinib. The second oral abstract I would like to discuss is one that was presented by Dr. Patrick Shofsky and colleagues, which actually looked at a new novel KIT inhibitor. And he presented some of the data in a preclinical GIST xenograft model, and which actually has subsequently led to a clinical trial. And then there were 3 posters that were presented at CTOS, of which I think would be quite relevant to our community. One by Dr. Guan and colleagues, which actually looked at their experience of doing surgery after patients being treated with ripretinib. And then, of course, we also have Denise Matoya's and colleagues' presentation, which was actually a LifeRaft group initiative looking at the multi-phase comprehensive genomic sequencing in patients with GIST. And then lastly, there was also a poster that was presented by Ketil Boyle and colleagues from Norway, which actually looked at the circulating tumor DNA detection in first-line treatment in patients with advanced GIST. So I think to begin with, I'd like to discuss the first abstract, and a little bit of a background is how we've always been prognosticating patients with GIST. And for those who are involved in the community, you'll be well aware that throughout the years, we've had different ways of essentially identifying the risk of recurrence for patients with GIST. Started off close to 2 decades ago with the NIH criteria, which really specifically looked at the size of the GIST and how active it was replicating in terms of the mitotic index. And throughout the years, we've incorporated different aspects of the tumor biology, which has made this sort of nomogram or made this risk stratification more representative, as well as more validated. Having said that, though, throughout the years, in actual fact, we all know that mutational status, be it KIT exon 9, KIT exon 11, or even non-KIT associated GISTs, do have implications on whether or not they might recur, and of course also has an influence on the type of treatment that they may or may not respond to. But if you look throughout the years of all these specific nomograms, in actual fact, the incorporation of this mutational status has only been done in 1 or 2 of these grading systems. And specifically, most of the patients which were entered into this database to create this risk stratification actually had exon 11 KIT mutations, and only a very small number of them had KIT exon 9. And of course, we know the biology of this, as well as the sensitivity to treatments, are different. So why are we specifically looking at patients with exon 9 mutations? Well, it's because these are still relatively rare compared with, say, exon 11, and it is associated with other known prognostic features, such as the presence of it being in the extragastric sites. I think it's important for us to also identify this because of its potential sensitivity to sunitinib, but less sensitive to imatinib. And certainly when we look at the prognosis of high-risk GIST patients who have received imatinib, we have some data that's been presented previously, which looked at 5-year relapse-free survival of up to about 70% and 10 years relapse-free survival of 50%. But this is actually mainly for patients who have KIT exon 11 mutations, and we don't necessarily have the data that would represent patients with KIT exon 9 mutations. So in this particular abstract that was presented by Dr. Napolitano on behalf of his colleagues, which is really an international collaboration looking at how we could prognosticate patients with exon 9 mutated GISTs who were treated with adjuvant imatinib. And in total, they identified 231 patients with high-risk exon 9 GISTs that were treated adjuvantly. And this is an international collaboration involving mainly 23 European sites, 2 US sites, as well as, of course, the LifeRaft group contributing in terms of some of the patient data as well. They've done a univariate and multivariate Cox regression analysis, and what they've done essentially is develop a new prognostic nomogram specifically for patients with exon 9 mutated GISTs. In total, what they found is about half, slightly less than half of the patients were male patients, and of course the remaining would be female patients. The parameters in terms of the demographics of the patients is what you would expect. Median age of 55, size. A very small number of these patients had a gastric, as in the just being in the stomach. but most of the patients actually had GISTs elsewhere aside from the stomach. About 17.7% of these patients presented with tumor rupture, of which, of course, is a poor prognostic factor. And a majority of these had a high mitotic index, and also patients were also treated with adjuvant imatinib. Now, there's no clear data to show that a higher dose of imatinib in exon 9 be used in an adjuvant setting is necessarily better. But out of this particular cohort, close to about 30% of the patients were treated with a higher dose imatinib of 800 milligrams per day. Now, this is the data, which actually looks at the relapse-free survival of these patients. And essentially what they found is in patients specifically with exon 9 mutated GISTs who were treated with adjuvant imatinib, the 5-year relapse-free survival was 54%, and the 10 years relapse-free survival was 32%. And this is compared to what has been historically described in GISTs in general, of which most of the patients were exon 11 GISTs, which actually were had a higher relapse-free survival data. So essentially what that really means is patients who have exon 9 mutated GISTs do tend to have a worser or not as good prognosis than patients of exon 11 GISTs with a shorter relapse-free survival. And specifically looking at some of the factors which may be associated with this prognostic change, they found that patients who were male, patients who were slightly older, patients who had larger GIST tumors tend to be patients who did not do as well. Specifically, though, also patients who actually had their tumors in the stomach actually did better than the patients who had tumors that were outside their stomach. And of course, if the GIST activity is higher in terms of its mitotic index, if it's the tumor was more rapidly replicating, then the patients actually did not as well. So I think it is important for us to have this data specifically for exon 9 mutated GISTs because they do behave differently biologically. And I think it's very important for us to understand this specifically to exon 9 mutant GIST patients. So the take-home message is that now we finally have some available information specifically for the KIT exon 9 population. We know that prognostically they don't do as well as patients with exon 11 mutation. And this really helps provide the framework. So then we can then have a more representative comparison to know the natural history of patients who carry the exon 9 mutant GIST, and then be able to say plan subsequent treatments for them, or if we are planning other novel treatments to know what the natural history would be. So I'll quickly move on to the second abstract I'd like to discuss. This was presented by Dr. Shofsky and colleagues, which is essentially about a new novel KIT inhibitor known as IDRX42, or previously known as M4205, which essentially is a type 2 inhibitor of KIT, and it has a broad coverage of KIT mutations, including KIT exon 11, KIT exon 17, as well as 13 and 14 as well. So the importance of this is the fact that in terms of the prior approved treatments that we have, including imatinib, sunitinib, regorafenib, as well as ripretinib, they do have some selective association with specific mutations. But for this particular novel KIT inhibitor, it does tend to have good activity across the range of all the different KIT mutations. And I think the other important aspect is the fact that it has a low or no brain penetration. And with avapritinib, which was previously studied in patients with GIST, of course, the issue is some of them can cause CNS or neurological effects because it penetrates the brain really well. And in actual fact, this particular compound has very low brain penetration. So we anticipate that the neural toxicity or the CNS effects would be less prominent. So in actual fact, Dr. Shofsky presented the preclinical studies. So this compound has subsequently just recently entered clinical trials in terms of treating human patients. But Dr. Shofsky and colleagues were presenting their data of which the drug was tested preclinically in the laboratory, including also in vivo studies in mice. Without going into too much details, essentially they used mice models, which actually harbored various types of GISTs with various types of mutations, including, say, KIT exon 11 and 17, KIT exon 13, a KIT exon 9, as well as also one which is specifically just KIT exon 13, and then treated at various doses of this particular drug. And what you can see actually is the fact that in this preclinical study, it does appear that the usage of this particular drug can actually shrink or actually reduce the growth of the tumors that were in these mice models across the board. And they did seem to perform better than also treatment with, say, sunitinib as well as imatinib. And if you actually look at some of the specimens that were actually removed from the mice after being treated with this compound, this IDRX42 compound, you can see that there is a significant reduction in the cellularity, as well as some evidence of myxoid degeneration in the samples, really indicating the fact that there is some cell kill in terms of reduction of the tumors. And also reduction in the mitotic activity of the tumors as well. So essentially what they have shown is the fact that this is a relatively promising drug in the preclinical studies. And in actual fact, this drug IDRX42 has now already gone on to phase 1 clinical trials. The trial in progress poster was also presented at CTOS this year by Dr. Suzanne George and colleagues, which essentially is an early phase clinical trial trying to identify the optimal dose to be used for subsequent investigations. And later on in the exploratory cohorts, there will be plans of treating patients who either have had just imatinib only, or in patients who've had progression after, say, sunitinib or an additional agent, or actually in patients who've had treatment of all 4 of the approved agents, really trying to identify in which specific space is most appropriate in terms of the efficacy of this particular treatment. So the take-home message really is there is a new drug of which there is a lot of promise in the preclinical setting. And in actual fact, it has already gone on to early phase clinical trials. We'll be expecting readout of this particular trial in upcoming meetings. Upcoming ASCO may be a little too early, but maybe in the next ASCO, for example. And do watch out for the data of this particular compound in upcoming meetings. Now, there are 3 more posters that I would like to discuss. I think one of the posters that really caught my attention was this single institution analysis of patients who had metastatic GIST tumors who were treated with ripretinib and then subsequently went on to have surgery. Now, this is a single institution analysis from the Sun Yat-sen University in Guangzhou, China. For those who may not be in the know, Sun Yat-sen University is one of the biggest cancer centers in southern China. And actually, I think in terms of China as a whole, it's probably the 2nd or the 3rd largest. And they have a very strong sarcoma as well as GIST unit. In this particular abstract, they identified 34 patients who were treated with ripretinib between June 2020 and June 2022. And out of these 34 patients, 7 of them actually had surgery after being treated with ripretinib. And these patients were in various lines of treatments, including patients who were treated in the 2nd line setting, 3rd line setting, as well as the 4th line setting. Now, this is just the demographics of the patients who were included in this particular analysis. And you can see that they included patients who had KIT exon 11 as well as 13, 11 and 17, and 11, 18 mutations. Mentioned the fact that there were patients treated in various lines of treatment. Most of the patients were in the advanced setting in terms of the lines of treatment. And in actual fact, these are typically the patients that you would see in clinic. Now, in the bar graph here on the right, what they've done was in the 7 patients who actually went on to have surgery, they compared the response to ripretinib, which is the ones in blue, compared with the response that they've had in their prior lines of treatment. And what you can see is in some of the patients, the usage of ripretinib led to shrinkage of the tumors or stabilization. There were also patients who had surgery because in actual fact, some of the tumors were getting bigger. And I think in the conclusion that they've decided to bring home, in terms of the patients who were treated with refitinib and then went on with surgery, it was deemed to be a safe approach in the sense that the surgeries did not lead to increased number of complications. The amount of, say, blood loss during the surgery was not particularly high. And in actual fact, the duration of surgery, which sometimes is an indication of how complex or how difficult the surgery is, was not particularly long in patients who were treated with refitinib either. And in actual fact, this has a good safety and efficacy profile in patients who were treated perioperatively. And in actual fact, in patients who actually led to shrinkage of the tumor, this may be one of the options to improve the survival of patients. Having said that, this is a very small single center study, and there was no real comparison to patients who were never treated with refitinib or patients who never had surgery. So I think this is a conclusion that is a bit far-fetched at this particular moment in time, but it is very promising for us to consider looking at specific studies to see how we would compare patients who are, say, treated with refitinib continuously, or patients who are treated with refitinib and then go on to surgery. So the take-home message really is the fact that surgical resection after the use of refitinib is feasible. There was no increase in terms of apparent risks of bleeding or wound complications. And I think the, again, challenge is identify which particular patient would benefit from this approach. But specifically, maybe it's for patients who have tumors which have quite a few tumors, but maybe just one or two which are progressing, and you try to remove the ones which are not responding to treatment. The next slide that, the next poster that I would like to highlight is an effort by the LifeRaft group, which I believe you may be well aware of, presented by Denise on behalf of her colleagues, and Sarah, of course, is a senior author on this particular poster, where essentially it is a patient group-led project looking at the recruitment of patients into a specific registry. And there's also a biomarker analysis as well. And maybe Sarah can also highlight some of the efforts that they've taken during the Q&A session. But my understanding was that this was a one of the key efforts that's being championed by the LifeRaft group, and specifically for patients who are residing in the US who never received any form of, say, genomic testing for the GISTs, and also an active member in the LifeRaft group registry. They were recruited into this particular project, where they will have access to essentially genomic sequencing of the tumors, which would improve our understanding of their disease and also contribute to the scientific efforts that's being made in the community. So they started off initially with a smaller panel, which is a 20-gene panel. And this is the flow charts, what we call a consort diagram of what the clinical trial is about, where since the initiation of this project, there were 104 individuals which have expressed interest in joining this particular project. Some of them were not eligible because of these particular reasons. And in total, about 55 patients, or 53% of the patients, were deemed eligible. In about 23 of these patients who contributed their samples, in actual fact, they have not had prior molecular testing. And you can see that this diagram here on the left-hand side, the bar graph really shows the distribution of the different types of GISTs that were in the community, predominantly being KIT exon 11, but there were also patients who carried KIT exon 9, as well as the non-KIT, non-PDGFR kits, GISTs as well. In the patients who've had prior testing, which was found to be KIT as well as PDGFRA wild type, in actual fact, some of them with further more specific testing were subsequently identified to actually carry KIT or PDGFR alpha mutations, but there are also, again, the other non-typical KIT associated genomic alterations that were identified. Specifically, there was one patient with an NTRK3 ETV6 fusion, which of course has significant implications because we now have, of course, NTRK inhibitors, which may be quite useful in this particular patient or this particular group of patients as well. So I think this particular effort has been able to provide genomic testing for patients who did not have it done previously, or in patients who've had it done to really broaden it in terms of a next generation sequencing platform to identify the ones which would not be tested by just single PCR tests, as well as just reconfirming whether or not they have or have not the presence of the typical KIT or PDGFR alpha mutations. And this was the conclusion that was presented by Denise, where essentially their efforts have found a more accurate individualized treatment plan for patients because of doing a comprehensive genomic profiling. And in actual fact, the phase 2 study is underway, where they're actually looking at additional genomic drivers where the panel will be expanded. And instead of the 20 gene panel, they're looking at a 648 gene DNA panel, looking at also other biomarkers, including microsatellite instability or tumor mutational burden. And I think, again, this is a space that we should be watching, and we look forward to seeing this data in upcoming conferences as well, which will really help paint the landscape of GIST genomics in the community. The take-home message is this project was initiated by the patient's community, and this is feasible and meaningful. And of course, it reinforces the need for molecular testing for all GIST patients at the time of diagnosis, because you can see that there are patients who have not had it done, or patients who've had it done, but then after on repeat testing, identify others potential biomarkers. Now, lastly is an abstract that talks about circulating tumor DNA presented by Dr. Boyle and colleagues from Norway. But a quick background on what circulating tumor DNA is, just a couple of slides really to talk about the fact that traditionally we've been using a tumor tissue assay, as in we take biopsies on the tumors or look at the specimen that's been resected after surgery, and then we could do various types of molecular testing. But circulating tumor DNA typically is the usage of blood, where with blood taking, we're then able to identify the tumor-specific DNA that's circulating within the circulation, and then to do various molecular tests as well. Now, Dr. Kettle and colleagues, Dr. Boyle and colleagues presented his data on the use of circulating tumor DNA in GIST patients. This is a study from Norway, and essentially in the patients who were initially treated in the first-line setting with imatinib, they had plasma samples collected at baseline after 2 to 4 weeks, and at each time when the patient had various evaluation at time of disease progression. In total, they recruited 28 patients, and 16 of these patients actually had circulating tumor DNA detected at the time of diagnosis. And what they found was, in congruence with other publications previously, the presence of detectable circulating tumor DNA is associated with a poorer prognosis. And that's really associated with the fact that the chance of you having this tumor DNA being detected in the blood is higher if you have more disease or you have rapidly growing disease. So essentially, these patients typically had a higher disease burden, and then therefore, in actual fact, the prognosis was worse. Interestingly, though, in this particular study, in this particular cohort, the circulating tumor DNA dynamics was not associated with outcome. And what that really means is the fact that in some of the situations, when we see a rapid drop in the circulating tumor DNA, it's a sign of the fact that the treatment is effective. And in general, we would believe that some of these patients will fare better than the ones who do not have a rapid drop. But in this particular group of patients that were treated in the first-line setting, we're unable to see this. Now, this may be because of the fact that this is a very small group of patients. And the other issue is the fact that this is in the first-line setting, and typically most of these studies are done in the subsequent line setting. But in any case, I think this particular abstract is really worth highlighting because the theme of circulating tumor DNA is really quite hot in the field of GISTs. And I think this really adds to some of the data that we already have in the field. Now, just a couple more slides just to end off, to really put the issue of circulating tumor DNA into perspective. And you may be well aware that using the circulating tumor DNA, in actual fact, we could do molecular profiling, so identifying which particular KIT mutations the patient may have, or specific resistant mutations. Potentially, at least in lung cancer, as well as in breast cancer, we've been able to do treatment response monitoring. The usage of ctDNA now is being championed as one of the ways of early cancer detection before you actually see it in the X-ray or CT images. And in situations where patients who've had treatments during the adjuvant treatment or even on follow-up, what we call the detection of minimal residual disease. Now, I think these particular approaches have been shown to be useful in various types of tumors. We're establishing the evidence of using ctDNA in these 4 different situations in GIST. Again, more and more projects are being presented in upcoming conferences, so do watch this space. And I think will be quite interesting in terms of the community to see where we're at in terms of our technologies. Now, I just wanted to end by talking about a recent ASCO plenary session that were presented by Dr. Sebastian Bauer and colleagues, looking at the INTRIGUE study, where they were then looking at the exploratory ctDNA aspect of it. I'm sure you're actually well aware of his recent presentation, and you may have even heard it online live at the very time when he was presenting it. But just by way of background, the INTRIGUE study is the ripretinib study, which actually is in the second-line setting, randomizing on a 1-to-1 fashion between ripretinib as well as sunitinib. The data has been presented previously, where in actual fact, they found there was no significant difference in terms of the treatment effects of patients treated with ripretinib versus sunitinib. Now, in this particular ASCO plenary session, Dr. Bauer and colleagues were presenting the biomarker data, where in actual fact, patients who were recruited into the study also had a circulating tumor DNA next generation sequencing done. And during this ASCO plenary session, of which I think will also be repeated during the ASCO session proper in June this year, he presented the data showing the fact that patients who were recruited into this particular trial had that ctDNA next generation sequencing done. And in terms of distribution of patients, they had patients who carried various types of resistant mutations, including exon 13, as well as exon 17, as well as 14 and 18. And there was a fair distribution in terms of patients who were randomized either to the sunitinib group or the ripretinib group. I think what's most interesting is the fact that looking at the various groups of patients, be it they carried the exon 11 and 13, 14 mutation, or 11 plus 17, 18 mutations, they fared differently in terms of being treated with either ripretinib and sunitinib. And what you can see is in the patients who actually had exon 11 mutations together with 17, 18, being the resistant mutation to imatinib, they actually did not respond well to sunitinib, but responded fairly well to ripretinib. And I think this is one of the beauties of using circulating tumor DNA, really to try to tease out which particular patient may benefit from which particular treatment aspect. Now, in the clinical trial itself, when it was designed, the circulating tumor DNA was incorporated into the study, but it was never being used to randomize patients into the two different treatment arms. So therefore, in actual fact, some patients benefited, some patients did not benefit. And then at the end of the day, the total or the mean patient actually did not do any better than being treated with sunitinib. But now we're able to tease out which patients may be able to benefit better. And I think this is very important in terms of designing which treatments we give our patients. Now, of course, because of the fact that this was not the original primary analysis of this particular trial, so therefore there is now a phase 3 randomized multi-center trial, which is about to start in some centers or having started already, which now looks at randomizing patients between ripretinib and sunitinib, but also specifically in patients who only have KIT exon 11 plus 17, 18 mutations, and not the ones with 13, 14. So I think we're looking forward to getting this data collected and approved and then therefore read out. And I think this would probably be one of the game changers in terms of choosing which treatments for which patients, and also moving this now approved fourth-line drug to earlier indications for our patients. So in conclusion, I just want to end by saying the fact that in terms of the abstracts that were presented at CTOS this year, I think a lot of it was placed on molecular classification. And of course, now knowing which specific genotype of GIST the patient carries is an integral part of routine clinical practice. This is important for diagnosis, for prognostication, as well as for making treatment decisions. There are new treatment strategies for GIST, and this is tailored based on the different molecular characteristics. And this potentially can also change at the time of resistance to initial treatments. And I think lastly, being able to involve the patient's community, such as during the molecular profiling project, has allowed us to move the field forward together in a more speedy manner. So lastly, just want to highlight the fact that the next CTOS meeting will be held in November. This year, it will be held in Dublin. So we're looking forward to a large attendance from both sides of the Atlantic as well as Asia. And certainly there is also a big interest within the patient advocacy community to come join. And we always look forward to welcoming patients and their groups to our meetings as well. The second thing is, ever since the most recent CTOS meeting, we've been trying to engage the community of interested parties in sarcomas, not only the ones who attended the meeting, but also through social media. We have started a new initiative called CTOS Tweetos. And in the most recent meeting, we've had various individuals who are leaders in their own field tweeting specifically about the CTOS meeting. And so certainly for the patient community who cannot attend CTOS meeting in person, you will be able to keep in touch with the latest updates of the meeting through social media. And certainly I would strongly encourage you to follow these particular individuals. In the upcoming meeting, we'll probably have new Tweetos ambassadors, but certainly do remember the hashtag CTOS Tweetos, and come November, you'll be able to get instant feeds of some of the updates that's being presented. So with this, I'd like to end, and I'm sorry for going slightly over time, and I look forward to discussion and happy to answer any questions that you all might have. Thank you.
Amazing. Thank you so much. This was a fantastic overview. There was a lot that took place at the conference. There were a lot of features, both on stage and also in the posters regarding GIST. So we couldn't get to everything, but I think you provided some great highlights. So I'm just going to jump into some questions that came in. You talked about circulating tumor DNA, and I was really happy that you slipped in about the ASCO plenary session that just took place like a couple weeks ago. That was great. So do you expect that ctDNA testing will eventually replace mutational testing of GIST surgical samples, or will ctDNA only be used for studying GIST tumor progression? And are you doing ctDNA testing in Hong Kong? And then, sorry, one other follow-up to that was, and in light of the Bauer results, shouldn't all future GIST drug clinical trials incorporate ctDNA?
Yeah, those are both great questions, David. Thanks for the questions. I think the second question first. In actual fact, yes, I think all future GIST trials should incorporate ctDNA testing. Now, going back to your first question, though, I think right now it really depends on what how accurate and how validated the technology is. I think initially for surgically resected samples, it's still the tissue-based analysis, which is key, mainly because of the fact that the technology in terms of detecting various types of mutations and the broadness of the panels is still bigger and better in terms of tissue NGS. Now, ctDNA has its convenience, and certainly in the situations of tumor progression, it's quite useful, mainly because of the fact that it's less invasive. And certainly in situations where patients have had various treatments, you would expect that there will be some heterogeneity in terms of the tumors. So some of the tumors may carry some mutations, some of the other tumors may carry different types of mutations, and supposedly, in theory, if you are doing a circulating tumor DNA looking at blood samples, you would get a representative representation of all the different types of tumors. And therefore, you would get a good landscape of all the different types of tumors that's within the body. Now, the problem, though, is there are various aspects of circulating tumor DNA which may lead to what we call a false negativity, because it's really dependent on whether or not the DNA from the tumor is being shed into the blood circulation, and whether or not your timing of taking the blood is most appropriate. I mean, the dynamics of the DNA that's being released into the circulation is dependent on how rapidly the tumors are growing, whether or not some of the tumors are dying, what we call tumor shedding, how close the tumors are to blood vessels, for example, and all that may actually affect whether or not you're able to detect it in the circulating tumor DNA. So in general, the belief is if you want to have a more specific and analysis, then a tissue-based approach is more appropriate. But in situations where you want to have a broader base assessment, and you have multiple tumors of which it is not feasible to do multiple biopsies, then a circulating tumor DNA approach is appropriate.
Just in terms of a global perspective, I know that sometimes it's you don't always have countries or laboratories that can do the tissue paraffin testing. So possibly the ctDNA could be a replacement for that if it's available in that country.
Yeah, definitely. So I mean, because by virtue of the fact that with ctDNA, typically right now in terms of commercial availability, it's sent to a particular company, be it in the US or Singapore, the various companies which are doing it. So you're right. I mean, in situations where your particular, say, community hospital may not have tissue-based NGS assay accessibility, then just getting the bloods taken, sent off to a central facility, in actual fact, may be one of the options.
So I just also want to ask a question about, somebody just asked it before I move on. It's related to ctDNA. Can you have ctDNA testing if you do not presently have any tumors on the CT scan?
Yeah, so I think that's something that's being explored at the moment. Now, in some of the other cancers, such as lung cancer, for example, we're looking at this situation called minimal residual disease. And in a way, that's exactly what it is. It's in patients who may not necessarily have any tumors that's picked up in their regular follow-up CT scans, but whether or not we're able to accurately detect the presence of tumor DNA in their body, and which may be an earlier indication of disease relapse prior to it being seen on the imaging. So certainly, because if you to be able to see it on the CT scan, it needs to be a certain size, and certainly also with CT scans, you're typically imaging from the bottom of your neck to your pelvis, but there are other regions in the body where a metastasis may occur. And the technology is being explored in lung cancer. For GIST, I think we're still in the exploratory phase, but potentially this would be a way of possibly even eventually in the future replacing regular imaging. If we could do a blood test instead of regular imaging, which of course has radiation risks, then this may be more beneficial for our patients. But we still need to build the science for that.
That makes sense. Somebody actually had a follow-up question about the INSIGHT trial. For those with KIT exon 17, I thought it was already known that sunitinib is not effective. So someone with exon 17 has the chance of getting the control arm, sunitinib, if they sign up for the trial. This would definitely make you think twice about joining a trial. Very insightful.
Well, yeah, I think I think there have been prior publications, the earlier studies, retrospective studies, looking at the fact that sunitinib seems to be better in patients or in samples which are exon 9 and 13 and less effective in 17, 18. But I don't think there was a clear prospective clinical trial which proved that. So I don't think it is necessarily wrong to be treating patients when there are no other better options in terms of using sunitinib in patients who have exon 17 or 18 mutation. But certainly I think with this particular trial we are now seeing the difference, and now we have more choices in terms of treatments, so that becomes relevant. And I think the other issue is the testing of 17, 18, for example. I mean, is it representative of all tumors? Or is it just one of the tumors that was biopsied, and then there's a possibility that patients may harbor just of other mutations at the same time? So in a way, the beauty of this particular study, which is looking at circulating tumor DNA, is in theory, it's more representative. So the ones which did not have, say, exon 13 mutations detected, if they have multiple tumors, the chances are they don't carry tumors with exon 13. So I think, again, we're still building the data and the science, but in a way, I agree. If we have more choices now, potentially we're going to choose different treatments, not based on the line of treatment, but based on the molecular characteristics.
So sometimes patients get confused between the ctDNA that's talked about now versus the plasma level testing, or the testing about the drug clearance in the blood. I was wondering if you could help distinguish that for patients who will listen to this, so that they understand the differences and the applications.
Sure. So, for the last 45 minutes or so, we talked about ctDNA, and essentially what it is looking at the tumor-specific genetic material that's being released into the blood circulation by virtue of the fact that the tumors have blood supply, and as the tumors replicate and die, some of this is leaked out into the blood circulation. And it's essentially then using the blood. So within your blood, you have your own DNA, right? You have your own personal DNA, but you also have tumor DNA. And what they need to do is they take the blood, they isolate out what is your DNA, and typically it would be the DNA that's in your white blood cells, so they need to remove all that. And then they need to identify specifically short fragments of DNA, which is tumor associated. And then we use that to do various types of testing. Now, you can use that to do a PCR test, specifically looking at various types of, say, exon 9, exon 11 mutations, or you could do a larger panel next generation sequencing test, which we've also been doing in tissue. Now, the other testing that Sarah just mentioned is the blood level testing, and that is actually a completely different test. We're also still using blood, but what we're doing is looking at the levels of the drugs that's been taken in. So previously, there have been some studies looking at the drug level of imatinib, and of course, in situations where the drug level is low, it may be associated with not so well of a response to treatments. And we've realized that the metabolism of imatinib is different in various people, and this may be associated with the different genomics of different ethnicities. We know that, for example, in Asians, I believe the imatinib levels are typically higher in terms of blood. So everybody, if everybody's taking 400 milligrams per day, the blood levels in Asians may be higher than Caucasians, and I guess it was one of the approaches to tailor the treatment and to adjust the dose of imatinib accordingly. I think this approach is falling out of favor, and there are less people doing that now. But in situations where the belief is the drug is not dosed to an adequate level, this may be one of the approaches.
Great, thank you for that response. Okay, so we have some other questions that came up. Did I understand correctly that the longevity of patients who have that KIT exon 9 mutation is shorter than other mutations?
So based on the data that was presented in the first abstract, the endpoints that was specifically looked at was relapse-free survival. So what that really is whether or not these patients recurred. When we talk about longevity, we're talking about overall survival. So whether or not, the total life expectancy is less. I don't think we've established that data specifically in that particular abstract, but we would probably need to look at the data more closely and follow up for a longer period of time to really establish that.
What about any treatment update on adjuvant imatinib use in terms of the length of Exon 11 versus Exon 9 usage, dosage?
Yeah, again, this was not presented in the CTOS meeting this year. I think right now we're really looking at 3 years versus 5 years. And I think the data is being collected. We have the PERSIST trial that was presented, I think, maybe 2 years ago, but that was a single arm trial. And I think we're still looking for the 5-year data. Again, the differentiation between Exon 9 and Exon 11 was never built into those studies. So I don't think we'll have much data specifically looking at that. But again, through the efforts of Dr. Napotanano and colleagues, we could probably do something similar later on to try to tease out the data.
There was a question about how effective Gleevec treatment is. I think it's definitely set a high bar in the oncology world because it has been so effective for GIST. We actually do have patients who even responded here who are in the chat who've been on it over 10 years, 18 years. So I think it's very encouraging that it definitely has helped with longevity. Yeah,
I think, despite all the discussions about new agents, we also talked about ripretinib, talked about regorafenib and sunitinib. If you looked at the survival improvements, none of these compare as well as imatinib in the first line setting. So there's been a lot of development in terms of what to do next, but by and large, I think most patients do benefit most from imatinib. And as Sarah's pointed out, many patients can be on it for a very long period of time. So it's still a very important drug. It is a very good drug. So make sure that if you're appropriate for usage of imatinib, we use that first before anything else.
Yes, agreed. I think if we can just speak about research, there was an individual who said, well, how can I help with your studies? And so I think that there are times where patients are like, what can I do to help contribute to research? How can I advance research? What is the LifeRaf group even doing to help support research? So I'm happy to start off with an answer here, and then I'd like to also toss it to you. Sure. So the LifeRaf group has been involved in patient-powered research for many years. It's really how we began as an organization. We do have a patient registry paired with a tissue bank, and we track patients over time. And this is across the globe. So it really helps us understand patients with different characteristics and different mutational types in terms of what their response is to treatment and how long they're on treatment, and that's also quite insightful for future studies. We did contribute, as you saw, Dr. Loong mentioned Denise's poster, that the data that we contributed has helped with, some of those collaborations with our friends in Europe and elsewhere. And so I think that the message for people who are listening today is, if you're not part of our patient registry, or you have not donated tissue, I strongly encourage you to do so, because that really does help us advance research. If you have not gotten mutational testing, I encourage you to join our mutational testing project because it's free, and you can learn more about the mutations that you harbor and see if that could be insightful for your own clinician in terms of how to manage your disease and your treatment course. We also collaborate with institutions and academic centers. So that is also in addition to what our registry can do. So I want to now move on to Dr. Loong. He's been heavily involved with research. He just went to a research meeting in Europe, I think last week or a few days ago. So I will let him talk about what's going on with research and how you can get involved.
Yeah, I'm sure. Thanks. I think as Sarah's rightly pointed out, I think everybody can contribute in terms of research. Now, certainly, I think for some of us who, some of the patients, for example, who are living or being treated in centers where there are clinical trials, then definitely it would be something that we would, as a clinician or as an investigator, I would very much encourage you to join. In general, for oncology treatments, we also believe that clinical trials is a very important treatment aspect, which really should be given opportunities to all patients if possible. Now, granted, having said that, not everybody will have access to a clinical trial, and I guess then it's really through the efforts that the LifeRaft group has initiated, as Sarah has pointed out, which potentially is accessible to everybody. My suggestion is reach out to your physician or your clinician to see whether or not they're aware of any clinical trials within their center, or whether it's possible to refer to a neighboring center. GIST trials are not, I mean, a lot of GIST trials are international global trials, but in terms of the community, it's still smaller than some of the other common cancers. And sometimes it does require 1 or 2 referrals to get to a center which actually has GIST trials. And even if it's short of doing a trial, well, being a part of a trial, or even contributing to the LifeRaft group's efforts, just increasing the awareness of GIST in the community is already quite meaningful. For example, we've just recently done some education in the general community in Hong Kong about what GIST is. I would tell you that maybe 80% of the population, when you tell them GIST, they think it's stomach cancer and not necessarily a completely different type of tumor. And I think just raising the bar of general awareness is useful. And lastly, it's really also making an influence or an impact in terms of the healthcare system for patients with GIST. Unfortunately, with the treatment of GIST, it can be quite expensive. We're talking about various types of new targeted drugs, which really improve the outcome of patients, but many a times it's quite expensive. So reimbursement strategies is something that's worth studying, and whether or not the patient community can have a voice that can be heard by the government of wherever you are, or the reimbursement people for drugs, and really just getting the awareness improved so that whatever outcome it is, we could improve the outcome of patients in general.
That was a phenomenal response. Thank you so much. I have to echo what you said, because sometimes people think like, who am I? I'm just one person. But I think like by sharing your story, by speaking to your physician about how can you find more patients and get information to them, or refer to the LifeRaft group or referral centers, is so important. Because the LifeRaft group, a lot of people find us online, but we know that there's a lot more patients out there. And so by people doing their part, by just talking about it and just shedding more awareness, is, I think, really important in terms of people's contributions to advancing the field and identifying more patients. So thank you for those responses. I just want to also thank you for your time and your presentation today, and also just how you've been such a great collaborator with the LifeRaft group. Dr. Loong presented updates from ASCO last year, and now CTOS, the ASCO plenary session, and he's also going to be working with us for future conferences. We love when he presents, and I think it's very clear and thoughtful. So we look forward to continuing to have your presentations, and I want to thank everybody for your time today, for joining us. So enjoy the rest of your day.
Thank you very much.
Everyone.
Thank
Bye.
you. Bye-bye.